Good morning. Welcome to everybody to the first session of the Saigon Cardiovascular Intervention Forum 2024. It's very easy to remember SIF 2024. And my name is Thuong Dung. I'm from Thuong Dung Hospital, Ho Chi Minh City, Vietnam. I'm very pleasure to moderate this session, the first session of the meeting. And I'm very honored to be co-chair with Dr. Kwan from the Mayo Clinic, Arizona, America. And the first, I would like to introduce the first speaker, the expert, Professor Pham Manh Hung from the Vietnam Heart Institute, Hanoi. He is a leading interventional cardiologist with over 30 years of experience, specialized in coronary intervention, valve disease, and structural heart disease intervention. And today, Professor Hung presents the topic, dangerous shock. We'll exchange how we treat and cardiogenic shock patient. Please, Dr. Hung.
Thank you, Professor Thuong Dung, dear Chairman and colleagues. It is my pleasure today to share some of our comment and idea. Actually, it's in Vietnam so far. We the impeller micros actions flow pump is not available in Vietnam. But last time when Dr. Dinh Duc Huy asked me to select the most interesting trial in the years, I found that it is a very interesting and very important. It's the danger shock trials. So I think in the future it may change some our idea and some our practice in terms of the treatment of STEMI patient in Vietnam and as well in the world. Sorry. It's not working. I'm actually typing. Sorry, as you may be known, cardiogenic shock occurs frequently in our daily practice in patients. It's a QMI. So far, it still remains a percentage, something about 8 to 10% in the whole patient is a QNI, and about 40 to 50% was die. Despite a lot of the advantage in the modality for the treatment and a lot of the new technology, but you can see here for over a decade, the mortality over time is remain very high, something around 14 by 50%. And this is data in my center for 4 years ago, and we found that for patients with cardiogenic shock, the SCAI C, D, and E, after 30 days, the survival is something just only about 30%. I would like to say that in my center so far we only have IABP and VA ECMO, but the use for this one is cardiogenic patient is still limited, and we don't have microactions or perfusion pumps so far. We don't have. So you all know that in cardiogenic shocks, the patient may have some problem when the output is decreased, but indirectly, when we use mechanical circulatory support device can increase cardiac output, may have a benefit. But however, you can see it is very disappointed that the IABP shock tools did not show the benefit when using IABP. And recently with the NSHOCK's routine use of ECMO, VA ECMO for the patient with cardiogenic shock is also didn't show benefit. But finally, so for the community of the interventionists. In the recent ACC 24, we can see the light at the end of the tunnel with the reason shown by the Denver stroke trial from Professor Moller from Denmark. So, previously, in principle, you can see here in a cardiogenic shock in a QMI patient, there are overlapping of the three mechanisms with the LV failure, RV failure, and also cardiac arrest. So also microaction flow pump may have a benefit when increasing the cardiac output, and especially for benefit for the patient with the LV failure. So the hypothesis of this trial is routine use of the microaction flow pump impeller CP on top of standard guideline direct care in patients with acute MI and cardiogenic shock result in the lower mortality compared with standard care alone. And this is includes the patient with acute MI with hypotension and hypoperfusion with lactate is more than 2.5 and LVEF less than 45 and was randomized when shock was diagnosed. But the exclusion is includes a comatose out of hospital cardiac arrest and RV failure, and also may have some mechanical complications. And you can see it is very brave trial. From the beginning, it's come from Denmark, but from the beginning phase, it's come very slowly, and after 2019 to 2023, and go to German and UK. So that's why you have the names. Danger shock is Denmark and Germany shock. So trial here, and this is a trial flow. You can see here. After screening for almost more than thousands patients with QMI and excludes the majority of them, and 360 patients was randomized for standard care and using some impeller with on top of the standard care here you can see. And this is the diagram of the study with a STEMI with cardiogenic shock with LVIF less than 45% was a randomized 1-1 when cardiogenic shock is the first diagnosis as soon as possible, and follow up all-cause mortality by 6 months. And this is patient characteristic. You can see the age, median age 67, and majority is men is 80%, and 22% LD or left main countries, and 72 multi-vessel disease, and SCAI classification for the shock is 55% class C and 45% SCAI class D or E, and you can see here. And it is very important that is only 4 hours from onset of STEMI symptom to randomize. It is, I think, to some extent, in some country like in Vietnam, it's sometimes too difficult because patients usually go to hospital a little bit late, and when they develop the cardiogenic shock, usually it's a longer time like that. So I think it is a very, very important. The first trial to use mechanical circulatory support for the cardiogenic shock have a positive result with the using the impeller can reduce absolute 12.7% of the death by any cause after the 180 days, and number need to treat just only 8, so that we can treat the as a patient to save the one life. It is very, very important. And also it shows that it can reduce needs of vasopressor and inotrope, and it's also make a faster lactate clearance in the CICU. But the benefit come at a cost. Now you can see here is a total number need to harm even lower than number need to treat is only for 6. That means we treat 6 patients with impella, we can get one adverse event like severe bleeding, limb ischemia, or renal replacement therapy, or sepsis, something like this. And in terms of bleeding, you can see 26.7 in the impella group and 15% in standard care group. And here you can see the in the group of the patient with impella and then upgrade to and also to ECMO. The ECMO is have a high risk the percentage of the bleeding, and also of course the patient with impella also have a very high risk of bleeding. In terms of the acute kidney injury and renal replacement therapy, also higher in the group of patients is impella. You can see here it's not only related to the disease severity, but also to the device-related factor. So it is really the concern when we apply the result of this trial to our daily practice. And you can see here in the subgroup, may have some thing to see in the female group, and it is author conclusion, the use of the implant on top of standard can reduce death from any cause in select patients with acute MI and cardiogenic shocks. And implant were associated with less need to vasopressor and faster lactate clearance. And also the concern that this was associated with an increased risk of device-related bleeding, acute kidney injury, and limb ischemia. So the questions, why did Dengue success when other failed? So as I mentioned before, it is may have the most benefit in the group of patients with the LV failure after the acute MI. It is, I think, it's a main mechanism, and how we can apply and generalizability in our group. And after the trial come out, there are some paper to estimate about 15 or less than 15% is eligibility for the use of the impella. So with the estimate about the 800 heart attack in US a year, so that would be about 20,000 would be have a criteria like in the Dengue shock trial, so we can apply. And also there are another meta-analysis to show that in the select patient with mechanical circulatory support in compared to the routine therapy may have some benefit. So I think it is very important that we can select very carefully the patient to have the most benefits over the harm when we have some very cost with the harm when we use a device for in our practice. So how to put in our clinical practice? According to the author on this trial, so that if the patient have a candidate for mechanical circulatory support after shock team evaluation first, and then we evaluate if a patient has a mechanical complication, we have to ask for the surgery. If no, we consider the patient with a comatose after our hospital cardiac arrest. If no, so if they have a low cardiac output, low BP, and increase in lactate, and we looking at the RV failure or oxygenation problem. If no, we can right away to do the femoral impella. If yes, you consider to use the VA ECMO. If the patient with our hospital cardiac arrest with comatose, yes, we may have some question to ask. If need or no need to have a mechanical circulatory support. But in the Bob trial with almost 800 comatose outhospital cardiac arrest patients, so not all of the all of that patients need to have mechanical circulatory support. So it means that we can select carefully the patient and the group of our hospital with a cardiac arrest. We can consider and have a good team to do something. So this is for the branch of the comatose our hospital cardiac arrest. We consider on the vasopressor inotrope and optimize fluid status. If increasing to needs of Sozac as a drug, if no, we continue to post-cardiac arrest management without the mechanical and circulatory support. If yes, we look at the low cardiac output. If no, we continue to treatment. If yes, we go to the consider to use impeller or via ECMO like this. So it is my take-home message. The dengue shock is a guideline changing trial. You can see here for the QMI have a two strategy for the improve our prognosis. For the revascularization strategy trial, the shock and especially complete shock already changed the guideline. But for MCS device trial, IABP shocks have to decrease the degrees of the recommendation, and L shocks may have some change in the new guideline. And for the dengue shock, I myself believe that in the future it can have some position in the recommendation for the patient with cardiogenic shock. So in practice, I think so. We can see in the dengue shock trial with the 5 practical tips. The first one is the focus on patient selection. The second, to decrease delays in care as soon as possible. And the third one is to create a shock team, and we can preconize AMI cardiogenic shock care. And of course, we need to mitigate the complication because you know the benefit of the dengue shock was decreased by some complication in relating to the even cardiac care or even in the vascular access. So it is my thank you so much for the attention.
Okay, thank you for excellent presentation of Professor Pham Manh Hung. The presentation on the impeller, a very effective mechanical circulatory support, but for a long time, certainly data for the recommendation. So I hope in the near future we will have some change. Thank you, Professor Hung. We will certainly many opinion or discussion from panelists. We will discuss the last session. So the next speaker, we would like to invite Professor Kwan with the topic, the potential paradigm disruption of prevent. Please.
All right, good morning, Mr. Chairman. Thank you very much for that kind introduction. This has been a really great year for Asian studies, and given that we're in Asia, we're going to switch around and now start talking about Asian trials for a bit. So my topic for today was the potential paradigm disruption of the PRESENT trial. I was present at ACC 2024 when this trial was presented, and I think the world was not ready for it. The room was quite quiet, even though at the very moment it was being presented, there was a total solar eclipse moving across the United States just 100 miles away from our presenting site. So as an Asian person, that has some meaning for me, right? This might be a sign that this is an important study. So today we're going to look at the lecture overview. First of all, we'll review very briefly the history of the vulnerable plaque concept. What is the modern definition of vulnerable plaque? What are the criteria for intracoronary imaging detection of vulnerable plaque? We'll look at the PREVENT trial together, the design and findings. And then we'll talk about study limitations and controversies, the implications for current clinical practice, and thoughts for the future. So the history of vulnerable plaque, it actually goes back for about 150 years, but in 1989, James Mueller categorized these plaques as hemodynamically insignificant albeit dangerous lesions as vulnerable plaques. I mean, they can rupture, but they are not ischemic, okay? So the modern definition basically comes down to that, then we move on from 1989 to 2003, and we say, these are thrombosis-prone plaques or plaques with a high probability of undergoing rapid progression. And the first stab at trying to define this was primarily histological. It came from the pathologists. So the pathologists were obsessed with this idea of the TICFA, the thin cap with the large lipid core, or fissured plaque, or endothelial denudation with superficial platelet aggregation. They could only talk about what they could see at the time. And in the subsequent years, this is a 2017 review of what is a vulnerable plaque. The focus continues to weigh heavily on this TICFA concept. So really, they talk about IVUS with virtual histology, which most of us, even though this has been around for almost 2 decades, don't use, right? They talk about optical coherence tomography, which is actually, it's not that easy to find the exact spots when you're doing a long run. And then obviously near-infrared spectroscopy. It is useful, however, to go back to Greg Stone's study, the PROSPECT study from 2011, so that we once again examine the question of what did they find in that study with regards to IVUS, because everybody talks about TICFA. But in his paper, you could clearly see that if TICFA was present by virtual histology, there was higher risk, 4.9 versus 1.3% in 3.4-year follow-up for MACE in that lesion. However, if you add an MLA of less than 4, it almost doubles the risk to 10.2%. And then if you add plaque burden greater than 70%, this takes your relative risk by almost a factor of 10 times. 20% bad outcome versus 2% without any of these features. So, I think based on this, the findings from that study, and given that Greg Stone was part of this group, they also included that very important grayscale IVUS finding of greater than 70% and less than 4, which is different from TICFA, right? So if you look at the PREVENT trial, right, this is from the Asan Medical Center group, Professor Park. Basically, they looked at any significant epicardial coronary stenosis, diameter stenosis greater than 50%, reference diameter must be 2.75 to 4, which is non-ischemic. So they must do an FFR and it's greater than 0.80 with any 2 of the following. Number 1, MLA less than 4. Number 2, plaque burden greater than 70%. Number 3, the lipid-rich plaque on NIRS. Or number 4, TICFA by OCT or virtual histology IVUS. And they randomized on both sides 803 patients to PCI with goal-directed medical therapy versus goal-directed medical therapy alone. And then they looked at the primary endpoint, which was target vessel failure at 2 years. In the initial part of the trial was designed to look at the absorbed BVS stent. But halfway through the trial, or 1/3 through the trial, that stent was discontinued, and they had to then switch to the Xience stent. And so this is the overall schema, 5,627 patients with intermediate stenosis screened over 6 years. 40% had positive FFR, so they got stented. Then in the negative FFR group, they then imaged to look for this high-risk criteria, and ultimately they ended up with 1,608 patients randomly assigned to preventive PCI plus OMT or OMT alone. 1/3 of those patients got absorbed stents, and 67% of those patients, 2/3, got Xience stents. So that's a very important finding. It's also important to see what the clinical presentation was on initial thing. And most of the patients were stable angina, 83% stable angina, and the 17% were ACS patients, but mostly unstable angina. So this is not primarily a non-STEMI or STEMI trial, even though that was the inclusion criteria. So it's mostly a stable patient. If you look now and you ask the question, what did they see to define this? Almost every one of the patients is MLA less than 4 or plaque burden greater than 70%. That's 97% of your patients. The nearest criteria, or TICFA by OCT or VH histology, was less than, less than 7%, the TICFA criteria, and the nearest criteria about one quarter of the patients. So most of the patients are actually IVUS-defined, grayscale IVUS-defined high-risk patients with that criteria. The lesion length on average was about 23.7. The MLA was small, so 2.78, and Dr. Fauzi asked an important question this morning. Less than 4, if the reference is small, that's pretty much a lot of our patients. However, it is important to realize that these patients, the reference vessel diameter for them to be eligible is 2.75. That's the minimum. So 4 MLA in a 2.75 is quite a lot of plaque. Okay. So what did they find? Target vessel failure at 2-year follow-up. OMT alone was 3.4% versus 0.4% preventive PCI plus OMT. At 7 years follow-up, the curves, after that initial divergence, then become parallel all the way to 7 years. So 9.4 versus 6.5%. It is extremely important to understand the effect of what the BVS inclusion had on the overall outcomes. If you look at OMT alone, right, at 7 years, you see up that, almost 9%. If you look at the BVS cohort caused the curve in the PCI arm to really push upwards. If you excluded the BVS patients, if this had been a trial of pure Zion's patients, your 7-year incidence rate is 1 or 2%. That is a big deal. And it means that even though many people still dismiss this trial as not ready for outcome, if this trial were to be repeated with current generation DES, you may see a completely different story come out of this. Okay? So what were the individual components of the primary composite outcome? It was not death. It was not target vessel MI. It was ischemia-driven target vessel revascularization, and this is a non-blinded study, so that's important. And it was hospitalization for unstable or progressive angina. So non-blinded study, so this, I think we have to be careful. When we look at the subgroup analyses, at 2 years, there was no difference in any subgroup, but at 7 years, if the PCI was being performed of a non-target vessel under ACS conditions, it favored preventive PCI. And we all know about the prevention trials in STEMIs. These are different patients compared to chronic stable angina patients. Number 2, if the median diameter by QCA was greater than 55%, once again, right, the more your stenosis, the more likely you are going to get outcome. And of course, from what we saw from that last thing, if you got a BVS, it was a complete wash. But if you got a Zion stent, this was strongly in favor of the trial results. When we ask ourselves, what was the medical therapy that was being undergone, right, by these patients? And you find that either high-intensity stent, so in a study where you're supposed to be as aggressive as possible, still you only get 60% of high-intensity statin or moderate plus ezetimibe. And this is probably not the medical therapy that we would be chasing ideally in a patient that we would have. If you look at the LDL numbers, the mean LDL was 90 to begin with, and at the end of the trial, it dropped to like 60 or 70. So it didn't even hit the ESC guidelines of less than 55 if you're trying to be aggressive with things. So, not quite sure what that means. So what are the limitations? A, open label, introducing the risk of placebo effects, ascertainment bias. B, the observed rates of the primary outcome was substantially lower than expected. So this was a hard, but once again, if you took away the BVS group, you'd see a different story. The selection of imaging modality to assess plaque vulnerability was left to operator discretion, do what you are best at. And then there was a bit of crossover in both sides. And the study did not collect data to examine the cost effectiveness of a preventive PCI strategy, right? It's a 1 in 30 difference. And the DAPT use was obviously greater in the preventive PCI group. So before we get all excited, once again, we do have to remember that there's a big body of literature as well that talks about the myth of the vulnerable plaque, right? What Valentin Fuster has shown overall is that it's not just the vulnerable plaque, but it's really the volume of plaque in a patient that drives outcomes. And that's from the little table there to the left. And it's also important to remember that even if you don't stent them, most vulnerable plaque will actually become non-vulnerable in follow-up imaging just with medical therapy. So this is pushing against our current hypothesis. So what are the reasonable implications for current clinical practice in 2024? For sure, despite these fascinating conclusions, we need much more work needed to justify any kind of change in practice. It is now, I would say, reasonable to define vulnerable plaque on grayscale IVUS as less than 4 and greater than 70% plaque burden. We need to move away from this TICFA idea, I think, overall. Number 3, if you find high-risk plaque features beyond your planned zone of stenting during IVUS or OCT-guided PCI, you should consider extending your stent to cover that area. I think that's a no-brainer, right? As long as it's technically reasonable. And you need to ensure that the medical therapy is as aggressive as you can possibly make it. And nowadays, we have so many tools to do that. There's no reason why you should not. So what are my thoughts for the future? Number 1, this requires confirmation. We need large multi-center trials with the latest DES, preferably with intracorneal imaging optimization. What happens if we were to use, what would happen if we use DCBs in this cohort? We don't know, and that's many years to come. We have to separate out the chronic ischemic heart disease versus the ACS cohorts. Given the increased focus on lipoprotein A, we have to ask the question, and I think Korea should go back and look at this entire population again. Does lipoprotein A elevation affect the risk of the detected vulnerable plaque? We do not know the answer to that question yet, but it is obvious that there probably is a relationship. What is going to happen when we look at similar trials with future imaging modalities, CTA for high-risk plaque, angiography-based physiology, QFR, intracorneal imaging-based physiology, AI-assisted imaging interpretation, right? This story is definitely not over. However, as medical therapy regimens continue to increase in potency and efficacy, this will become a constant race between us and our medical therapy colleagues. Our PCI effects will continue to also need to be better. But it was very reassuring to see the 7-year outcome of like 1 to 2% in our current generation DS for this arm. There are 3 trials sitting around waiting to come out over the next 5 years. I think the enrollment finishes 2025 to 2027 for all of these 3. There's combined intervene in Belgium, which is OCT vulnerable plaque, FFR non-ischemic, and this is all comers, chronic or ACS. Then you have Interclima, which is from Italy, from Prati's group, and this is same OCT versus physiology-based non-culprit intermediate ACS. And then you have EPIC 28 vulnerable from Spain, which is the same thing, FFR negative, but non-culprit intermediate lesions in specifically STEMI cohorts. So those 3 questions are going to be asked at pretty much the same time, and we should see those results soon. Thank you. These are pictures from the last decade in Vietnam, adventures in Vietnam.
Okay, thank you so much for excellent presentation of Dr. Kwan Lee about the prevent trial that talk about. I think this trial having the new concept, preventive BCI for the vulnerable plaque. I think it's very interesting, and certainly it will be many things to debate. We will debate at the last session. And the next topic, we would like to invite Professor Cheem with the topic, impactful ASEAN study, IVUS, ICS, and ultimate DAPT. Please.
Thank you very much, Mr. Chairman. When I was asked to speak on what are the impactful Asian studies, I chose these 2, IVUS, ACS, and ultimate DAPT. The reason why I chose these 2 is because not only are these 2 trials integrated in one using the same population, but also because it emanated from Asia, which is something relevant. But actually, the most important above all is that these 2 trials are directly practice-changing, and my practice probably have been influenced by these 2 trials. And it's a privilege to come here once again, and I always like to show these pictures of Pham Manh Hung, the course director, who spent his year of fellowship at National University Heart Center in Singapore. So we're very happy that we play a part in his development, and certainly he has flourished and succeeded where he is right now. And I think he remains the first Vietnamese doctor to present an abstract orally at TCT. So nothing to disclose for this particular presentation. When you look at the use of intravascular ultrasound in PCI, there have been many trials If you see IVUS, XPLs, Ultimate, Renovate Complex, October, Illumine 4, and so forth, there were populations of ACS patients involved. But when you collect all of it together, the population's study of ACS is around about maybe no more than 50% of the populations involved. So there was never a study where you specifically look only at the ACS patients. But there were 3 looking at OCT versus angiography in ACS patients. But again, these were all very small studies. So specifically now we are looking at IVUS-guided PCI, which I understand is probably the only intravascular imaging modality in Vietnam right now, and OCT perhaps not so commonly used. So the aim of this study, which is IVUS ACS, is to investigate whether IVUS guidance compared with angiography for the implantation of second-generation DES results in fewer clinical events in patients presenting with ACS. And this includes unstable angina and STEMI and STEMI. And the inclusion criteria is important here. Patients has to have a biomarker positive to qualify for NSTEMI or STEMI. And when you don't have a biomarker positive unstable angina, you must actually have following criteria. So these are real unstable angina and not the wishy-washy type. So you must have a diameter stenosis of more than 90% on your angiogram, evidence of rupture plaque or presence of thrombus to qualify for a biomarker negative unstable angina. And these were the exclusion criteria: stroke, previous bypass, any planned surgery, life expectancy less than 1 year, and so forth. Now let's look at the primary endpoint here. The primary endpoint here is a composite of target-based vessel failure. Includes death, myocardial infarction, and a clinically driven target vessel revascularization. Now the secondary endpoint is also important. Now you look at TVF without procedural MI. You want to take away all this procedural-related MI, and individual components and stent thrombosis. So this is the statistical assumption. It was based on a 1-year event rate of 10% with a 28% risk reduction. So 3,486 patients is supposed to be able to give you a 80% statistical power. So this is a study actually was carried out in China and actually in some of the Pakistan and European country. But I have to tell you that the majority of the patients that were enrolled in this particular study were from China. So this was the randomizations and the study flow chart. So this group of patients with ACS were first randomized into either IVUS-guided or angiography-guided, after which they were put on the 1-month DAPT. If they have no events, then they will undergo a second randomization. The second randomization will now constitute the second trial, which I'm talking about, the ultimate DAPT. One group will continue with ticagrelor plus aspirin, and the other group will just simply have ticagrelor alone for treatment from 1 month to 12 months. So let's look at the baseline clinical characteristic, just because this is a randomized controlled trial, so you can expect the baseline demographics to be pretty similar. And there's actually a pretty good spread in terms of the types of ACS patients from unstable angina and STEMI to STEMI. Now, when you look at the lesion and procedural characteristics, this is now different. Clearly, when you use IVUS, you're likely to put in a stent that is larger. You're likely to put in a longer stent, and you're likely to perform post-dilatation. The contrast media and the procedural times are all a little bit longer compared to an angiography-guided strategy. But in terms of QCA results here, again, consistent. You get a larger minimal luminal diameter, a stent diameter as well, acute gain, and so forth. So let's look at the primary endpoint. When target vessel failure here, this is angiography guided, 7.3%. When you look at the IVUS guided, this is 4.0%, an absolute reduction of 3.3%, and this is statistically significant here. When you look at the subgroup analysis, and you find that it's pretty consistent across all the, there was no significant interactions among any of the subgroup. Even for the ACS group themselves, unstable angina and STEMI, there was no interaction. So it works for all kinds of presentations of ACS. When you take away the peri-procedural MI and just look at TVF, which is the secondary endpoint here, again, you see the IVUS reigns supreme here in terms of its reductions of target vessel failure. So when you combine the primary and secondary endpoints together, it's quite obvious that the target vessel failure is statistically significant. There was all a reduction of spontaneous MI, clinically driven target vessel revascularization, and so forth. Well, there's one important thing here. It's not just about using IVUS. It's actually making sure that the results actually fulfill that of what we term an optimal IVUS criteria. And because there were left main lesions involved, and there were also non-left main lesions involved, they used two different sets of criteria. Ultimate was a trial from Nanjing, so it was mainly non-left main. So this was the criteria for optimal IVUS. Left main, it uses Excel. So among all the criteria, they added on MSA, minimum area. But in the IVUS group, 80% of patients fulfill the optimal IVUS group. You find that people who don't fulfill the optimal IVUS group do just as badly as the angiography guided. So it's not just about pulling IVUS, it's know how to interpret the results and then apply the solutions accordingly. And so why were the optimal IVUS results not achieved in this particular study? Many of them did not achieve the expansion index of more than 90% compared to the distal reference diameter. Plaque burden more than 55% present is about 7%, and then suboptimal MSA. Dissections were very, very few. So in conclusion, as far as the IVUS ACS is concerned, is that an IVUS-based strategy reduced the one-year rate of the composite of death, MI, and clinically driven target vessel revascularization. So my take here of this particular study here is that now you can expand the use of your IVUS beyond just a stable ischemic disease. You can now use it in all your ACS setting to achieve a good results. The second part of the same study, integrated study, is the ultimate DAPT. And ultimate DAPT attempts to answer a very important question. The current treatment as far as ACS patients post-PCI involve a one-year DAPT, and oftentimes includes a potent P2Y12 inhibitors, which could be ticagrelor or prasugrel. And usually after 1 year, people will just go on an aspirin single monotherapy. But now we are suggesting that there are some limited data to suggest that actually using ticagrelor as a monotherapy shortly after the initial 1 month of DAPT may just give you as good a results. We know from the TPAS trial, we know from the TICO trial that you can actually shorten the DAPT trial of a ticagrelor-based DAPT. So there were actually two primary endpoints to this study. You have to fulfill the first one, effectiveness, before we go on to the safety endpoint analysis. The first one is the superiority design. This has to show that it is more effective in reducing bleeding complications compared to ticagrelor DAPT. After you have fulfilled the effectiveness, then we want to make sure that there's no difference in terms of a clinical outcome, specifically stent thrombosis and so forth, in a non-inferiority design. Again, this is a statistical assumption, but I just want to tell you that this has to be tested hierarchically to make sure that the alpha value of the statistical significance is preserved. So you have to prove effectiveness first before you start doing your safety analysis. So in a nutshell, this is a combination of IVUS ACS, second randomization now to ticagrelor plus aspirin, ticagrelor alone. Remember, this patient has to have no event for 1 month on DAPT before they can be randomized. So you don't want to confuse the picture here with event that occurs very early on during the inclusion. So the baseline characteristics are still pretty much matched because this is a randomized study. Culprit lesions characteristics also very well matched in these two groups of patients. Now we look at the procedural characteristics, also pretty much the same for these two groups of patients. So the adherence to the DAPT, I have to say here, is really, really very good here, in excess of 95% here. Most of the patients who were randomized to ticagrelor actually stay on with it, but there were a few patients that had to have a reduction in dose of 90 milligram to 60 milligram because of some intolerance. So this is about the same in both groups of patients. Then there were also a group of people who actually have to be converted and de-escalated from ticagrelor to clopidogrel. Now let's look at the primary effectiveness endpoint here, which is the reduction of bleeding. So bleeding with ticagrelor plus aspirin at 1 year, 4.6%. But just ticagrelor alone, after 1 month of DAPT, is 2.1%, a significant reduction of primary effectiveness endpoint. But I have to caution here, because this definition includes but 2 3 and 5. And BARC 2 is actually a minor bleeding, actionable but no doubt, but it's minor bleeding. It is not powered if you just look at serious bleeding of 3 or fatal bleeding of BARC 5. Now, when you look at the bleeding endpoints again, so it is clear that it's statistically significant. And because of this, when you look at the subgroup analysis, actually it seems to favors every single subgroup here. Okay, there was no significant interactions among the 12 subgroup. Now, let's look at the safety endpoint. When you look at the safety endpoint here, which is a non-inferiority design, did the shortened DAPT actually result in a higher ischemic endpoint? The answer is that no. So it was safe to actually stop aspirin after 1 month of DAPT in patients with ACS. But one of the endpoint, again, I want to highlight here in this study is that target vessel revascularization was actually counted as one of the Mackey events here. Obviously, a shortened DAPT is not going to impact on the target vessel revascularization. So perhaps this study is still a little bit underpowered with regard to heart endpoints. But nevertheless, it is still when you combine the Mackey and the net adverse cardiac event, it was in favor of a shortened DAPT duration. So when you combine, again, another way to show that Mackey, there was a net adverse clinical event reduction combining ischemia versus bleeding in patients on monoclonal therapy. But what is significant to us here in this ischemic event here is that there was a subgroup that didn't seem to benefit from a shortened duration of DAPT. And this is very strange because the older group of patients seems to have higher incidence of clinical endpoint when you shorten the DAPT. Now, we know that an older group of patients are supposed to have higher bleeding complication, and yet when you shorten it, they actually have a higher incidence of ischemic endpoint. So that part, we still don't know exactly how it comes about, but we'll probably have to study it further. And the other group that didn't quite match is that the IVUS group didn't seem to matter so much in terms of a interaction. So didn't seem to play out in terms of shortening of DAPT. So what can I take from these two clinical trials? I think the conclusion that we can draw here is that in patients with ACS treated with PCI with contemporary DES were free from any Mackey event after 1 month on DAPT, just treating with ticagrelor alone is good enough. And secondly, but this results obviously warrant the updating the practice and change in practice. So I'm start doing that now. So I'm going to stop all my patients after 1 month of their aspirin and just continue with their ticagrelor if they are on ticagrelor-based therapy. The current guidelines for ESC say it is a 2A recommendations for continuations of DAPT. And 2A to use intravascular imaging to guide ACS PCI, and 2B to use IVUS to guide culprit lesion, okay? But I think this one probably is going to change quite a lot. So my personal take as far as this two trials go is that IVUS has now been expanded to now lower MACE in patients with ACS undergoing PCI. Secondly, ticagrelor as a single therapy, I will urge you that perhaps may be good enough after a month of DAPT in ACS. So it's potentially practice changing, but bear in mind that there was this concern of about elderly group of patients don't benefit so much. This is overall still a very low thrombotic risk population. Majority are Chinese patients. Whether it applies to Europeans, we don't know. And we didn't have a specific group of high bleeding risk patients who perhaps may benefit most from this abbreviated DAPT regimen. Thank you very much for your attention.
Thank you very much, Professor Tan, for that phenomenal overview of two very, very important trials coming out of Asia. Next up, our next speaker needs no introduction. We have Professor Jung from Thuong Dung Hospital, who will be speaking about intravascular imaging studies of the year. Which of these have impacted our OCT-guided PCI?
Okay, thank you so much for a very kind introduction. My topic is IVI study of the year 2024 with impact on OCT-guided PCI. And I'm not one trial, a series of trials, so I briefly present. I not focus, I not go deep in the data, the interpretation, and the conclusion of the trial. I only focus on the role of the OCT, the value of the OCT, the significance of OCT in health optimal PCI. The first prevent, they focus in the lesion vulnerable atherosclerosis coronary plaque. The cone of triumph, they assess the effect of the colchicine on coronary plaque stability in ICS. The Calypso, they focus on the calcified lesions. The Occupy, the focus on the complex lesion. The October focus on the unintended deformation stent during bifurcation, and particularly left man. And the doctor left man, he focused in the left man. The first, the prevent trial, Dr. Kwan do the analysis and interpretation very much. I only talk about the role of the OCT in discover the vulnerable vulnerable plaque. Vulnerable plaque in here, the imaging definition for vulnerable plaque have us lead to of 4 criteria. First, minimum lumen area less than 3 square millimeter. 2, a plaque burden greater than 70%, and 3, thin cap fibroateroma by OCT or IVUS, and the 4, the limit plaque by near. So I think the OCT can determine, can discover the vulnerable plaque. This is the result of the prevent primary composite prevent at the 2 year, at the 7 year, with prevent PCI, preventive PCI plus the optimal treatment. It have the good outcome compared with only OMT alone. And the prevent deformations, we focus on the role of the OCT. As you can see, the composite risk, I don't talk about us. Almost vulnerable plaque can be detected by the OCT. And the second trial, the Calypso, they focus on the calcified lesion or severe, very severe calcified lesion. So they focus on to predict the stent under expansion. In the Calypso study, they do the OCT-guided PCI compared with the angio-guided PCI for the moderate to severe calcified lesion. And the endpoint, the post-PCI minimum stent area in OCT group compared with the angio group. And definition for stent under expansion, minimum stent area less than 2.5 square millimeter. And in the OCT guided strategy, the patient will perform 3 times OCT run. And angio-guided strategy only 1 time for at the result at the end. And this is the result, primary endpoint. You can see the minimum stent area of the OCT guidance, a better angio guidance, and with the very significant. And according to analysis of this trial, they have 3 predictors for the final minimum stent area less than 3.5 square millimeter. The first, OCT guidance, it can help to improve. The second, lesion length. And the third, the reference vessel diameter, bigger or small. So in the deformations, lesion length, reference vessel diameter, and OCT guidance for PCI were the independent predictor for the under expansion. And OCT guidance have a potential benefit related to the more appropriate plaque preparation, better stenting sizing, and more advanced PCI result optimization. And the impact of this result on clinical prognosis have to assess, of course. And the next trial is the doctor left man. They assess the optimize the result of the stent for the left man. And they assess by FFR, fractional flow reserve. And very surprised, the threshold of FFR higher, more common. It's a FFR value greater than 0.9. In the common value, 0.8. So I think very difficult to get the M. So this is the result, the primary endpoint, no difference between angio group and OCT group because FFR greater than 0.9. But when they do analysis, they discover some benefit for OCT, procedural success, the OCT better. With the structure-man position and cross-stand is better. So it can lead to a clinical driven target lesion revascularization better. So the doctor take-home message, we have OCT-guided more PCI optimization and significant greater procedural success, and maybe about a significant fewer target lesion revascularization. And the next trial, October trial sub-study, they search about the unintended stent deformation during bifurcation PCI, particularly in the left main PCI. They have 4 mechanisms, but in this trial they focus 2 mechanisms. The first, accidental abdominal rewiring. It means rewiring outside the stent. And when we use the balloon, when we do pre-dilatation, it matters USD. And the second mechanism is the guide catheter collusion. It means the guide of catheter jump in, some out, and it can do the USD. And as you see, the first accident abdominal rewiring, the frequency is very high, 50%. And for the guiding catheter some in, some out, you can see the location, off on the left main and off on the proximal left main, proximal stent S, proximal segment of bifurcation account for the majority of K. Distal segment bifurcation and bifurcation core and side plane ostium are very, very low, very few. And they discover the 2 EMA of the patient with untreated unintended stent deformation worse than no QSD. And they lead to the maze of the 1 year. The OCT guided PCI is better than angiographic guided PCI. So the take-home message, USD identified in the 9% of OCT guide K, and it can associate us with the serious procedural complication and worse clinical outcome. Left main bifurcation by PCI particularly rich for USD. And predominant mechanism were the guide catheter collision and undetected accident abdominal rewiring. And OCT can identify the USD, particularly left main PCI, untreated that USD can increase procedural complication with a long-term MACE. And the last trial is the Occupy RCT. In this trial, they focus on the complex lesion and complex PCI. This is the criteria for complex coronary lesion, CTO, long lesion, calcified lesion, bifurcation, unprotected left main disease, small vessel disease, instant restenosis by blood graft, acute MI, intercoronary thrombus, and thrombosis. And in this trial, they compare the clinical benefit of OCT-guided PCI versus angiographic guided PCI. This is the criteria for optimal PCI. For optimal PCI, it's met the acceptable criteria for all the components. The first, no edge dissection. The second, stent expansion, good and stent apposition. And it have a criteria lower, you can see. And this is the result of Occupy. Endpoint at the month become 3 months, 6 months, 9 months, 12. The patient with the OCT-guided PCI is better than the angio-guided PCI. So the take-home message, Occupy trial involving in patient with requiring PCI with DAS implantation because anatomically complex lesion. OCT-guided PCI led to the reduced risk of the 1 year composite of MACE compared with angiography-guided PCI. The main reduction of OCT-guided group were driven by the lowering spontaneous MI and TVR, without raising concern of the contrast-induced nephropathy. And in the OCT-guided PCI group, the patient who met the pre-specified Occupy OCT optimization criteria have a significant lower MACE rate compared to those with the suboptimal OCT result. These findings confirm the therapeutic value of the OCT as an effective intravascular imaging modality in treating complex lesions. And so the result of Occupy in combination with another trial support and further strengthen for the recommendation from the 2024 ECS guideline for the management of CCS. As you see, intracoronary imaging guided by IVUS or OCT is recommended for performance BCI on anatomically complex lesion, in particularly left main stent through bifurcation in long lesion with the class Kwan and level evidence A. And we hope the US guidelines should follow this similar. And my viewpoint, after the OCT related trial in 2024, after many OCT related trial studies in 2024, prevent on vulnerable plaque, Calypso on severe calcified lesion, October trial sub-study on unintended stent deformation, Dr. Leftman in the left man occupied for complex BCI complex lesion. With the finding of these researchers, we have more data and more evidence for OCT-guided BCI for complex lesion. I am confident that we can do optimal BCI for complex lesion under the guidance OCT. Thank you so much.
Thank you very much, Professor Jung, for summarizing what appears to be an extremely good year for OCT. So for those of you who don't use intracoronary imaging, please catch up. The next speaker we have is, I think someone else who also needs no introduction. He's a long-standing friend of Vietnam, Dr. Eeckhout from Lausanne, who was also one of the editors of the first edition of the EAPCI textbook.
Thank you, indeed. Thank you. Good morning, everybody. I'm happy to be here, and I want to congratulate Huay and Hung on setting up this meeting. It's not easy to set up a new meeting and to see so many people on this single day. It's a great success. So my study of the year is a mystery because you don't know what the title is. So I'll let you find out what it is. The one in the room who hips up first will win a prize. No conflicts to disclose. So this is basically the introduction of the paper in the New England. So those of you who have read the paper know already what I'm going to talk about. It's a trial coming from the north of Europe. That's all I can say. So what you see here, that coronary disease and aortic stenosis go hand in hand. 50% of patients do have it. 10 to 20% of TAVI patients undergo PCI. However, it's still a little bit in between if these patients we have stable, I say clearly stable, aortic coronary disease need or benefit from PCI when they undergo TAVI. And if you look at the ESC guidelines, we see that we are in the gray zone 2AC. That's what was in the latest guidelines. And I just show you this old slide that I presented at one of the APEC meetings 6 years ago, where I discussed the subject. This was basically at that time a meta-analysis coming from this part of the world that was, yes, more or less, no, you can do it, but really we don't know if you should do it. So that's basically the situation until this trial came out. Activation is a trial that was suffering from recruitment, only 230 patients included. I don't think you can say a lot. They stopped the trial because of failure to recruit, and the trial was non-conclusive. If you look at the results, well, basically no real benefit. The endpoint was death and rehosp at 1 year, and important to see that there was higher bleeding in the PCR arm. So that was what we knew up to 2024 until one of the major congresses where the Nordic Trial 3 was presented. This is the trial, this is the paper in New England, and if you look at the trial, it's basically a simple, straightforward trial, the way our Scandinavian colleagues tend to do that. So it's the number 3. There were 2 trials that were done before. It's an ambitious trial because they wanted to demonstrate superiority in this trial, open label, international, basically Nordic and Baltic countries. So what was the working hypothesis? It's basically quite simple one. They stated that routine PCI improves clinical outcomes in patients with significant coronary disease. What is significant coronary disease? Well, it's a quite, I would say, simple definition. A lesion of at least 90%, or FFR in case of doubt, with an FFR done or intravenously or intracoronary with the usual dose, and the vessel had to be at least 2.5 millimeter. So quite straightforward, quite easy in terms of design. Contraindications, they are listed over here. Well, they may limit the trial because no valve in valves. Severe renal failure was also an exclusion criteria. Non-STEMI 2 weeks before, and left main disease. We see quite some substantial proportion of patients with left main disease, and also patients with renal failure that come for TAVI. So that's certainly a limitation of the trial. Then very practical, very, I would say, pragmatic view. TAVI was done according to local practice, using the valve that you like and your current practice. And the PCI, as shown over here, aiming for complete revasc, and CTOs could be treated according to local preference. Initially, optimally prior to the intervention, but up to 2 days after TAVI was allowed. Primary endpoint, a bit different from the other trial. They added myocardial infarction in the combined endpoint with a follow-up of at least 1 year. And the secondary endpoints, that's a lot of things. That's any of the above, but you can see all the things that are added. I'm not going into detail, but they added a lot of other secondary endpoints in the trial. You can find them in the appendix of the study in the New England if you want to read it. The study population, this is a quite recent trial. It was a trial that was done quickly. 2/3 of the patients were included the last 3 years of the trial, where practice changed a bit. 12 hospitals in the north of Europe, a bit more than 450 patients, and there were 10 screening failures. TAVI was not done in 12 patients. I show you why. 8 patients in the PCI group didn't get under PCI neither. This is a little bit the screen lock. So they basically looked at patients in a modified intention to treat analysis with a bit more than 220 patients in each arm, which is not a big trial, but it's not a small trial neither. This is too small to read. I'll just tell it. Pick out the highlights from these slides. These patients were mostly 80 years old. They were not very overweight. They were mostly in class 3, and they had, most of them were high flow patients. As you can see, a mean gradient of 70. That's a severe aortic stenosis, as you can see. Now, if you look at the angiographic data, and this is also quite clear, these were simple lesions, mostly single vessel patients with a low I forgot to pick it up, with a low syntax score, but also with a low STS score, so also low risk surgical patients, important to know. Most of the patients had their PCI before, 74%, about 20 during, and a few after. Let's now look at the data. The style was positive for the combined endpoint. You see 26 versus 36%. And then it's important to look at the arrow below. So if I understand the trial well, and I think the more clever people in terms of statistics in the room will certainly understand better than me, we are not allowed to interpret the secondary endpoint separately because there was no correction. So, but we can see that many of the secondary tend to be positive in favor of the PCI. Look at MI, look at kidney failure, look at revasc, urgent revasc, and also look at bleeding. If you see that looks higher, it looks not in favor of the PCI, just like in the previous trial. Also, this was pre-specified, the subgroups, and we see that basically the only one that doesn't cross the line that tends to be significant is those patients with critical lesions. More than 90% seems to favor more from PCI, which may be a logical thing if you think about it. TAVI complications. What do we see from this slide? Well, we see that TAVI is a simple procedure and basically a safe procedure. Very few events in high-volume centers from the north of Europe. PCI-related complications, very, very few complications. As you can see, only 7 patients, sorry. So once again, the results in details, 26 versus 36% for the primary endpoint. And then to be interpreted with caution again, higher bleeding risk, that's what I quote say, better for patients with high-grade lesions, and less MI, once again, quoted with a safety mark. Study limitations. What about FFR in aortic stenosis? It tends to underestimate the severity of the lesion. Some people say that's maybe not well studied. We know from studies that patients who have FFR before and after TAVI, about 10% of the patients cross the line. So that maybe the effect will be minimal. And the other thing is that we know that patients who have a low FFR, who have aortic stenosis, they do less well. Patients were low-risk patients, low syntax score, low STS score, also low and not very severe in terms of surgical risk. Very few multivessel disease patients, no left mains, no non-STEMIs, that's a limitation. There has been changes in the antiplatelet therapy over the last 5 years, but I personally don't think this has a big impact on the outcome of the results. And finally, there are some uncertainties about the timing of the PCI. Honestly, I don't know the answer neither. I don't think it's that unrisky to do TAVI before PCI, because if you run into trouble in a left main, which was not in the study, before TAVI, you may really run into trouble. While a quick TAVI with a balloon expandable valve, personal opinion, may be safer, and then go for the PCI, at least in the very high-risk patients. But this is very, very personal opinion. My conclusion, so the working hypothesis of our friends from the north of Europe was right. They bet and they won. So PCI of stable patients with significant coronary disease, defined according to a pragmatic modern definition, that means a lesion visual estimate more than 90% or an FFR that is positive, is safe and improves the clinical outcomes as defined by the primary composite endpoint. And that's the composite endpoint that you see over here. Seems to come at the cost of higher bleeding, but we have seen that before. But maybe if you apply the results of the trial shown in this morning, maybe that may be different for the future. Seems to be more pronounced in high-grade stenosis. But on the other hand, I think also that what this trial shows again is that TAVI is really a safe procedure, certainly when it's done in simple lesions. And I just showed this slide because here in Ho Chi Minh, there's a picture taken December 13, so not far away from today, 2015, together with Huay in Tam Duc Hospital. Always nice to work together with our friends from Vietnam. And once again, congratulations on this excellent meeting here. Thank you.
Thank you very much, Dr. Eeckhout. So we have about 20 minutes for discussion. If we are very enthusiastic and want to skip coffee, we have about half an hour for discussion. So I think let's get started, and we probably should do one trial at a time because there's so much variability in the different trials that were presented today. So I think let's start with danger shock, and probably let's get some opinions from the end and then move downwards. So probably Jack, could you comment on the implications of danger shock for Asia?
Thanks a lot. I really enjoyed Professor Hung's lecture on danger shock, very, very important trial. A few key points that he raised, which I absolutely agree, is that the recruitment took 10 years. They screened 1,200 patients to recruit 300 patients. And what you like about it is that there was mortality benefit. What they did very well was that they don't look at 30-day mortality. You have to look further out. All the shock trials, you have to extend it to 180 days before you can see benefit. What I didn't like about it, based on the data, was the fact that there was a lot of heterogeneity between even the countries. And in UK, there's only one high volume center. So whether implementation of impeller or LV venting across Asia will bring similar mortality benefit, you're not certain. Again, the shock protocols in all these centers are quite varied. PA catheter is not pre-specified or mandatory. So I think there's still a lot of work to be done before it can manifest this mortality benefit at the price point of impeller at the moment. The other major thing is that in the APSC consensus statement for AMI cardiogenic shock that we just recently published in conjunction with SKY, recognizing the limitations in Asia, if you define shock, at least stage C and above, based on need for inotropes, LV diastolic or PA, wedge pressure, or lactate levels of more than 2.5, you can use any other adjunct left ventricular support device that you have on hand, which includes IBP. And this is recognizing the limitations and the needs of Asia Pacific. Because you cannot say you must only use impeller, you must only use ECMO, use whatever you can, but more importantly, we're endorsing a push towards early PA catheter use and the development of a shock team and shock protocol across Asia. So these are my comments for Prof. Hung's lecture. Thanks.
Yeah, and I think if you just do the math, I'm not sure how much impeller costs you, but there's no impeller in Vietnam yet. But in Singapore, I mean, in the United States, it's $40,000 US per impeller. If your number needed to treat is 8, that's $320,000 US to prevent one death in this clinical setting. I think for most of Asia, this is simply not a realistic equation at this point. If the price point changes, then obviously the math changes completely. So we have to just ask the question, as competitor and Me Too devices start to emerge, at some point does that curve actually cross, I think. So let's get some more opinions from this side of the table. Does any of you want to comment about whether in Vietnam or Malaysia, how danger shock might influence you?
Yeah, I agree with Jack. I think it's not just the technology. We have to look at the whole setting. The circulatory support system is not a definite therapy. In the context of shock, we know we need to support with resuscitate with support and the definite care. If you talk about cardiogenic shock in the setting of MI, I think if you zoom out, much of our focus really need to look at access and primary PCI. Many of us still are not doing enough primary PCI. Yeah? Short of probably Singapore, where you are an island, a nation where you can achieve a 99% primary PCI. So I think in our Malaysian National Registry, we realize our primary PCI is still much room for improvement, I would say. So how much we should invest into a technology for a shock, which is very much downstream with not getting early reperfusion, invest upstream to look at how to have more cath lab and more accessibility. We got to look at those contexts as well.
Yeah, I just want to give another perspective, because through this trial, I see a little bit different story. Because usually when we see the QMI's patient, we only focus for the blood pressure. And we try to put the inotrope, IABP, sometimes ECMO. But in reality, the LV lotting is really important. And in the trial, you use a device to reduce the LV, you unload the LV, and then you got the benefit from the mortality. So I think that it can change the way we're thinking about how we do the primary PCI. We not only focus for the blood pressure, but you also need to thinking how to protect the myocardium and also to unlock the LV.
I think one thing we've learned from the United States, our cardiogenic shock experience, is that the PA catheter is essential to this equation. And use of the impeller just in the room is, because we are talking about ACS cardiogenic shock here, is not enough, because most of these patients are going to leave your room with the impeller, and they will also hopefully be leaving your room with the PA catheter. One of the things about PA catheter is you can't just put it in if there's nobody to respond to the changes that we see in the measurements, in the time, in the hours and days after you send your patient out to the cath lab. And that requires somebody to be on site and some good nurse or whoever it is you've assigned to respond to the changes. If you don't do it, it's pointless as well. So I think one of the questions we have for Vietnam is, in the setting of cardiogenic shock here, how many of you would send your patients out with a PA catheter? Can we see a show of hands? When you have cardiogenic shock patients, does anybody leave with a PA catheter? So pretty much zero. And I think probably from a pragmatic perspective, in Asia, that is probably step one, right? That we need some sort of pragmatic trial of the outcome, of the efficacy. And the beautiful thing about the rise of artificial intelligence is that we may be able to build in automatic responses to the changes that we see in the PA catheter, so that the intensivity of manpower that's needed to monitor and respond drops significantly. And you put it in, and then the decisions that come from artificial intelligence about what to do next. What do you think?
Yeah, I think it's very interesting to discuss about the danger shock, but we're not enough time. So we move to the next presentation. It belongs to Dr. Kwan about prevent. So I think the new concept, preventive PCI, is very interesting. But how do you transfer the new concept to practical application? Or you need way more later, may way more some later? Yeah.
Yeah, I think I covered a little bit of that in my talk, but I want to hear from Dr. Fauzi, who always has very good opinions about the future of.
Yes, Kwan, you revealed the PREVENT trial, which put us on the crossroad. Because if you are dealing with a vulnerable plaque with functional normal, should we treat this kind of plaque due to we interrogate using intracoronary imaging or leave it alone? Because if you treat this plaque, it's you know that the Glasgow phenomenon is already putting the 40% plaque burden before its birth pop up to the intracoronary. So that's why if you just need 30% to say this is a vulnerable plaque with a thin scabs, and then if you are treat, how many you are going to treat? Because vulnerable plaque is everywhere. And when if we are treat this plaque, maybe we have to wait for the 3 upcoming studies that going to reveal the particularity in every vulnerable plaque. Because some vulnerable plaques is put on the very good side in the mid without bifurcation, but other vulnerable plaque in the bifurcations, if you are treat this, is going to have a plaque shifting and other things. That's going to be the worsening of the outcomes. So the other point is as you point out, the benefit of using DCB. At that kind might be DCB will work. We need of course we need a study about that. Thank you.
Yeah, you have probably some of the largest experience with DCB here. What are your thoughts with this idea of DCB in vulnerable plaque non-ischemic?
I think we know that the drugs are essentially anti-intimal hyperplasia. They prevent intimal hyperplasia, prevent scarring. But having said that, paclitaxel has been shown to have some plaque stabilizing effect. But whether they are anti-atherosclerotic, we are not certain. So I think when we look at some of these drug-coated balloon application for treating or prophylactic treatment of a vulnerable plaque, we need studies, specific studies to address it. Currently, we don't have them.
I think with the IVUS grayscale signal of greater than 70% plaque burden and the potential gain of late lumen gain in DCB, that might be also a fascinating space to watch. Any other comments from any of the panel members here? Jack.
Actually, I'm confused. So I'm always trying to put together all the studies that come before in combining with what we see in PREVENT. So we look at like courage, ischemia, even FAME for the stable coronary artery cohort. If there's ischemia as proven by some form of physiology, especially in the stable coronary syndrome cohort, your benefit is not mortality, but it's ischemia-driven PCI. There's a lot of crossover. But if you then combine with the PREVENT data, I feel that the beauty of the PREVENT data is the beauty of intravascular imaging as demonstrated by the ultimate and maybe ultimate DAPT and IVUS ACS trial. If you want to really define and then procure the benefit of a preventive PCI, you need to have beautifully done intravascular guided PCI. And I think comparing the subsequent talks on OCT versus IVUS, I'm still a bit disappointed by the benefit derived surprisingly from seeing so clearly on OCT compared to IVUS. I feel that then it tells me that seeing clearly on the intimal side may not be as useful as seeing depth and prediction of plaque volume for vulnerability. So I think I'm again confused. I'm not sure what to make of it, but the Koreans, at least from the ASEAN colleagues, when Dr. An presented it recently, he was very frank in saying that when they designed the trial in ASEAN, they expected the results to be negative. So when the result turned out positive, they were equally stunned as the primary investigators. So I think at least it was well conducted. It did show that if you use intravascular imaging on top of FFR negative physiology, you can potentially derive benefit by the selected outset, provided you do the PCI almost to like Jun Jie's and Chen Shaoliang's type of ultimate criteria adjudicated outcomes for intravascular imaging. So that's how I make of it at the moment. Yeah.
Thank you, Jack, for those very insightful comments. I think from a time perspective, we should move on to the IVUS, ACS, and ultimate DAPT next trials. Do we have any comments from our panelists? Dr. Fauzi, you want to?
Yes, I think Professor Tan is showed the IVUS benefit in acute coronary syndrome, but it implied that this is not the usage, IVUS usage, but IVUS guidance in acute coronary syndrome. That's why it's just usage doesn't mean that you can use this kind of intracoronary imaging to guide optimal treatment. In regard to acute coronary syndrome, it's quite a difference with the chronic coronary syndrome. If you are using intracoronary imaging in acute coronary syndrome, the benefit between the OCT and IVUS should be differentiated because IVUS can extrapolate, can identify the vulnerability, plaque rupture or erosions and the mechanism of acute coronary syndrome, but quite difficult using intravascular imaging, intravascular ultrasound. And the other point, when you are using intravascular ultrasound, IVUS, in acute coronary syndrome to optimize the treatment, what is the criteria optimal optimal IVUS finding? Because the optimal IVUS finding based on chronic coronary syndrome. In very lipidic plaque, if you are using expand the stent more, there's going to be slow flow or no reflow. That's why the expanding of 70% of minimal stent area is quite good compared with the more the expands. That's the way that we haven't get the decision regarding the optimal intracoronary imaging in acute coronary syndrome. That's my point.
I just have one comment and also one question for Professor Tan. So basically, through to trial, I think that if we can do the perfect PCI using the AVI or anything, then we can shorten the time for the APT. So the question is, can we shorten only with the clopidogrel rather than ticagrelor? Because in reality, in Asia, sometimes it's easier and cheaper for the patient to take clopidogrel. And if we can do the perfect thing with the IVUS, Professor Tan, do you brave enough to change totally only a single antiplatelet therapy with the clopidogrel?
First of all, there has not been a trial to compare clopidogrel as a combination therapy, as a single antiplatelet therapy after 1 month. So most of the trial is actually based on ticagrelor, as you understand, because it's more potent. And also in the acute coronary syndrome, we tend to use something more potent than clopidogrel whenever possible. So I'm not sure about Vietnam, but in Singapore, I think ticagrelor is probably the drug of choice for ACS patient. And because you have such a good potent results, good potent effect, stopping aspirin after 1 month, I think makes a lot of sense. The question now is, can we start with monotherapy ticagrelor right from the very beginning? That one, we still don't have the study to back it up. But clopidogrel as a single therapy right now, following ACS, I think we just need more studies.
I think also given the fact that we've ignored poor metabolizers for clopidogrel because it just hasn't really seemed to have meant anything. But if you were to switch in an ACS population to monotherapy, especially with the high prevalence of poor metabolizers in Asians, it could possibly be a problem. So I think for now, the smart play is to stick with ticagrelor or prasugrel and not try that yet until we have studied that specific question very, very carefully.
Can I put a word of caution there? Because I think Cheem mentioned it will change his practice, but I'm not so convinced actually. I think there is a study, Stop the ACS, that showed that short stopping of going to single antiplatelet from clopidogrel aspirin was negative in the ACS cohort. And I think the Plateau sub-study, which is the biggest randomized, if they look at the Asian cohort, East Asian and Southeast Asian are very different. East Asian has actually quite low ischemic risk, but Southeast Asian ischemic risk is double digits. So we're not talking about the same patient subgroup. And you saw in Professor Tan's IVUS ACS, the ischemic risk at 1 year is so low for ACS cohort in East Asian, which is quite well seen in the East Asian, but it's not the same for Southeast Asian. So I'm still a bit hesitant to endorse rapid switching to single antiplatelet, even if it's a more potent third generation after just a month across Asia. That is,
Okay, we're at time.
Just to comment that Stop DAPT is a clopidogrel trial, it's not ticagrelor.
correct. So clopidogrel answer is no.
So we're at 10:30, but I think we're having so much fun, we should just keep going. If you want to grab coffee and come back. But I think we should move on and talk next about the OCT-guided PCI sub-studies. Could we get some comments about from our OCT enthusiasts on the panel, people who do a lot of OCT, about your thoughts about the trials from this year? I'm going to ask Dr. Fauzi again because I know he likes OCT a lot.
Yeah, I think OCT is play a role in some situations, but IVUS is better in some situations, like the ostial part. And then the complex case, meaning that you have to use multiple pullback of the intracorneal imaging. Maybe IVUS is better than OCT. But the OCT have give you some insight of very good in terms of how to deal with the intimal side of the vessel.
Yeah, what are your concerns with that? Is it the contrast exposure? Because it looks like the contrast-induced nephropathy, there's no signal, even in the OCT trials. Like, is it just from the difficulty of just keeping repeat imaging with the OCT versus the IVUS, or are you more
Yes,
concerned about safety?
I think if you are using OCT, you have to point of interest which part of that you are going to use. So doesn't mean that you have to put all the contrast all the way to the vessel. Which one? And then you can reduce the contrast as well. Yes. But sometimes you are can use a saline is quite good enough.
Yeah, in the United States, we don't have the correction for saline. The FDA has not allowed us to turn it on, so we're not using saline yet. In Asia, are you all using a lot of saline OCT?
No, I use a contrast most.
Yeah. In my presentation, because I think for the long time, OCT have the Whitborn is not enough data. It's different from IVUS. IVUS have the large body of the data evidence. So, as you know, in the recommendation from the guideline, it always said the IVUS is class 1A. And maybe if we don't have IVUS, we can use OCT class 2A. But by now, I think more and more the data of the OCT more and more have for approval for the OCT. So the guideline of the ESC 2023 for the coronary, chronic coronary disease said in the complex lesion, we can do complex PCI under guidance of the IVUS or OCT and class 1 and level evidence A. So I think it's the change of the guideline. Yeah.
And Kwan, the potential benefit of OCT in if you are using 3D OCT in a bifurcations to remove all the strut the ostial side branch. Yes.
Yeah, just a practical comment about the unintentional stent deformity at the aortoosteo. So I like that study because it's very, very informational. It's so insightful that we have to be very careful when we place osteo stents. But when I change my practice to use OCT, I find that OCT for aortoosteo is not that easy because you got to really have a good injection of the contrast. I would probably still like to use IVUS for a few reasons. IVUS can give us real time. And in the setting of aortoosteo stenting, one thing we also should try to advocate and teach is actually real-time IVUS guidance of the stent placement. And I think that is very important so we don't have missing of the osteo as much as too much of the stent extending into the aorta. Yeah? And the other thing is, of course, from a practical point, the use of stent boosts can also be very useful. We always talk about complications to prevent them as much as possible. And I think it's important to learn about why this happens, the technique and tips to how to avoid crushing the stent edge, yeah? This pulling back the guide and so on.
Thank you. Dr. Kim.
I'm just comment in terms of the OCCUPY trial. Our center is enrolled the OCCUPY trial. In terms of the OCCUPY trial, data clearly show the OCT-guided PCI is significantly associated with the reduction of the better clinical outcome. But more important things is that in the OCT group is optimization group showed a significantly reduction of the event compared with the suboptimal event. Hazard ratio is 0.33. That means we have to focus on this PCI optimization when we use the intravascular image guidance, just not image catheter penetration. That is one of my comments.
I had a question to follow up on that. You know, there were so many different types of complex lesion subgroups included within the trial. Was there any attempt to look at, is there a specific type of complex lesion that had the most benefit versus others? You know, there was like almost every category you could think of was in there: CTO, bifurcation, calcium, Lang, blah, 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 blah. Did you all look at whether there was a subgroup that was better than others?
Now we are conducting the subgroup analysis in terms of the HS or CTO and the left main. And the more is the most different thing is compared with Illumian 4. Illumian 4 did not show there's any benefit of the OCT, but it's the Occupy trial showed the OCT optimization achieved it's the 71%. But it's the most of the randomized trial regarding intravascular imaging, just the optimization percent is the less than 50 or something like that. That is most the different thing compared with the Occupy and the Illumian 4 trial.
Which is very interesting because the ultimate ACS that you showed also had a 70 to 80%. Like, you know, that's very strange that we started off and we couldn't get to the number, but now we are getting to the number more and more and more. And the question is why? Is it because of lithotripsy? Is it because of something, you know, that I'm not sure what it is, but that definitely needs to be investigated. So I think we have to move on to the last trial, Notion 3. And I think one of the questions that I had are with regards to the implication of choosing a balloon expandable valve versus a self-expanding valve. In a cohort of patients who you expect to stent now, I think that identifies a cohort of patients that you should also expect to stent again in the future. And the issue of coronary access, can you really justify, or does it actually need to be studied to have the best possible coronary access, whether we should always be starting with balloon expandable valves in this cohort versus, like, because I've seen people just blow off, you know, they say coronary disease no longer matters, so I can stick whatever valve I want, and then they all stick self-expanding valves. And then when the time comes for you to get in there, when the patients come back, sometimes it can be really, really, really hard to get your guide into the coronary artery again to be able to go. So what are your thoughts about that?
The answer is come on first day to the Vietnam Heart Association meeting in Huay, because I'm preparing my lecture for that subject. but no, I think I'm trying to speak in terms of a company now. I think all companies are working on commercial alignment. They all do. And if you follow their rules, I think it's quite okay. I think also the technique of implantation makes a big difference. So I don't think there are big issues. It's only in terms of lifetime management of aortic disease that it will be a problem. But specifically for that cohort of patients that are, you know, the Notion 3 trial, I don't think it's a big issue. But of course, in the long run, it's a different story for sure.
Although in Asia, it might be more of a significant problem just because of sizing issues in Asia, the space around the coronary sinus, the distances and coronary heights relative are quite different for Asian patients because they are smaller compared to Western patients. So it might be an issue here.
Yeah, we don't know the answer, of course. And to be honest, the Nordic are big people. They are even, the average size of a Nordic people is very high.
We have a question from the audience. Come on up.
I have a question for you, Dr. Eric. We know that Notion 3 is the positive trial, which is for the revascularization. But when we see at the curve, the two curves just separate after 1 year. So do you think is there any risk factor that affect the result after 1 year? And we know that the result is driven by the reduction of the revascularization and the myocardial infarction. And we know that from the burn registry and the revival registry, the unplanned revascularization is just under 1% at maybe 5 years. So how about to make a trade-off between the bleeding risk and the myocardial infarction?
Yeah, I was also surprised by the data. Basically, The only thing, of course, is not surprising is that death rates didn't differ. The two others differed, and that I was surprised because MI I didn't expect it, and mostly it's the RESC that differs. But as you see, in the bottom, and we are not intended to interpret the results because they are not, the analysis doesn't allow to interpret the secondary endpoints that are the individual items. So it should be restarted in a new trial if you want to do that. Don't forget, it's 2 times 220 patients, which compared to modern interventional trials is a small trial. So I think we are not at the end of the story. I think so. Yeah. At least we have a positive sign.
Okay, I think with that we need to wrap up. We have 2 minutes for coffee, and then we need to prep the table for the next set of speakers. Thank you very much.